Guys, for my failure to be on time, but I promise to make it up for you by trying to move things along as appropriate as we begin the meeting. I think that we typically on these hybrid meetings ask someone on the staff to tell us who's in the room, who's in the virtual room, rather than calling on everyone to identify themselves. I see that Delegate Kerr has joined us. Welcome. But can we get a call out on who's attending or not?
Yeah, in the room.
In the room.
Start, Reggie.
In the room, we'll ask people to identify themselves directly on the call. We'll read who's listed on the screen. Okay, go ahead. In the room.
Hi, I'm Regina Bodner. I'm the Assistant Vice President for Hospice and Palliative Care for LifeBridge Health.
Good afternoon. I'm Peggy Funk. I'm the Executive Director for the Hospice and Palliative Care Network of Maryland.
Okay, and on the phone, Tracy, can you...
Let me just finish going around the room.
Okay.
Linda Cole, Maryland Healthcare Commission.
Tracy DeShields, Maryland Healthcare Commission.
Catherine Victorine, Maryland Healthcare Commission.
Winnie Hawk, Maryland Healthcare Commission.
Okay. And Tracy, you have the list online. You want to go through
Sure. Delegate Ken Kerr, Aaron Davis, Cindy Carter, Dr. Carney, Scott Brown, Elba Rivas, Deneen Bolin, Monica Escalante, Kelly Vontron, Johanna Ruth, Dr. Dan Morheim, Shirley Otis Green, Dr. Whit Dunkel, Amanda Stefano, Louise Knight. Let's see, I know. Those are the ones that are. Oh, and Rebecca Swain. Sorry, Rebecca.
Okay.
Did I cover everyone?
I think we have everyone. Welcome, everyone. In terms of just updates, I'm going to talk about the presentation to the commission. And then I'll ask Linda to talk about, or Peggy maybe briefly update us on the national meeting she attended and the CAPC reports. But Linda did present to our commission at our monthly meeting on May 15th. The commissioners were very interested in the progress of this work. What they did voice a preference for is on the interim report, which we view as a process report, that no preliminary recommendations be included in that because they felt they wanted to have an opportunity to weigh in before the recommendations, the proposed recommendations went to the General Assembly. Being mindful of them being the bosses of the commission staff, I think what our plans are going to be that in the interim report, as we conveyed to the commissioners, that would be an update on process, but we wouldn't be outlining draft recommendations in that report when it's sent to the legislature in early July. But we certainly are going to be talking about the recommendations over the course of the meeting today, and the fact that they want to also have an opportunity to hear those recommendations. Shouldn't deter anyone from being completely frank about the draft recommendations as they are presented today. I also note that a number of the recommendations relate to activities that the Medicaid administration would take on. Although the leadership has seen those recommendations, they have not yet weighed in on them. So I think recommendations pertaining to Medicaid need to be qualified, that as the work group considers them, we should be careful to keep in mind that the Medicaid administration has not yet endorsed them. We certainly would want their input and commitment before final recommendations are sent to the legislature. So with that qualification, I'll stop here. Are there any questions? Seeing no questions in the room, and no hand raised on the screen, I'll turn it over to Linda.
Okay, thank you, Ben. So Peggy, I know, has some exciting updates from national meetings on the development of or expansion of community-based palliative care. So Peggy, you want to give us a brief
Thanks,
update?
Linda. Linda asked me to talk a little bit about some legislation that was recently provided for consideration on the national scene. A lot of states, I know we're going to talk about this later, are now in the process of proposing their own legislation. But back at the beginning of June, NHPCO had their legislative fly-in. And I don't want to use too many acronyms for those of you that may not know. That's the National Hospice and Palliative Care Organization. So, and of course, that's when everybody comes in from all the states and they meet with their legislators and sort of, make some of those asks that are top of mind. But the one thing we really talked about for this particular event was the community-based palliative care demonstration model. And I'm really happy to report that on June 7th, that legislation was actually, that's my word, introduced. Thank you, Reggie. That legislation was recently introduced in the form of Senate Bill 1845. The sponsors of this legislation were Senators Rosen, Barrasso, Baldwin, and Fisher. I'm happy to report this was bipartisan legislation, which I think is always a good thing. And so I thought maybe I would just walk you through what the legislation is proposing. Just want to say that this has had 2 readings and is now with the Finance Committee.
You can just do a summary. I don't know.
I was going to do a summary. Yeah. I wasn't going to read it.
We started getting worried.
I do want to say that the bill is only 6 pages long, which is always good. It's at the, I guess, typical, 120 pages or whatever. Anyway, but what it does is it asks that CMI develop and implement a model to provide community-based palliative care for high-risk beneficiaries as a way of reducing emergency department visits and hospitalizations. So this will replace the care choices model, and they propose that it goes on for a 5-year period. They have a target population that really is those individuals that are diagnosed with a serious illness or injury. And there's a pretty extensive list of diseases, things like cancer, stroke, heart, Alzheimer's, and serious injury, among others. They propose that the providers of this benefit would be palliative care teams that work with hospice programs or that are independent of hospice programs, along with home health agencies and healthcare systems. So they also emphasize this should be a team-based approach for community-based palliative care. The location would be any beneficiary's home, and the services are really based on the patient's needs, along with caregiver support and, of course, mental health services. I thought one interesting thing about this proposed legislation is they also propose that access is 24/7, 365 days a year. And then, of course, they want to see metrics, quality metrics over that 5-year period. So very interesting legislation. And I just want to add one note that NHPCO recently partnered with NORC at the University of Chicago to determine the projected enrollment, calculated baseline of utilization, and cost of care for this proposed model. Excuse me. Based on the preliminary results and a conservative sample of enrollees, NORC found that this model can reduce the average total cost of care by 20% and result in almost $600 million in savings to Medicare, or roughly $143 per beneficiary model. So that's my report. And if anyone has any questions, I will be happy to answer them. Thank you.
Thanks, Peggy. Are there, do you see any questions?
Getting it through the House may be the challenge.
Yeah.
Thank you, Peggy.
Dr. Moore.
Dr. Moorheim,
Hi.
go ahead.
Thank you, Peggy. I just would point out it in the chat. There's an article that relates to this, the Journal of American Medical Association, about further benefits of palliative care. It's a recent article. Many of you may know it, but if you don't, you should, and it should be in our record. So I would urge everybody to take a look at that. Thank you, Peggy. Great report.
Thank you.
Thank you.
Go ahead, Linda.
Okay, so in your mailing, you also received some recent publications. These include CAPC's Spotlight on Home-Based Palliative Care, Payment Arrangements for Palliative Care, and Payment Primer. And those will be posted on our website as well. So as you recall, at our May 23rd meeting,
include the one that I posted as well.
Absolutely.
Okay.
That's
yes, we'll post them. So Rebecca Sweeney from SEA will presented some of the initial results at the May 23rd meeting, and she will now present the remainder of the results from the statewide survey. Okay, Rebecca.
You're on mute.
Yes, just one moment. I'm having to stop you sharing and then I will share here. Give me 1 second. Okay. All righty. Double checking that everybody can see my screen that says MHCC Palliative Care Survey additional findings.
Yes.
Go ahead.
Okay, perfect. Well, thank you so much for the opportunity to speak with you all again about the results of the survey that we conducted over this last year, reaching out to a lot of the different healthcare associations and, organizations in the state of Maryland. So just to give you a brief recap of who was included in this palliative care survey. This survey included 356 organizations comprising home health, hospitals, hospices, and nursing homes that were invited to participate. Out of these 356, 182 organizations responded to the survey with any type of response. As we talked about briefly last time, we did have a very difficult time getting responses from each organization, getting completed surveys and getting follow-up responses with when clarification was asked. So we did have 117 responses that were excluded as they did not meet the CAPC definition for palliative care, and or the survey was not completed by somebody who was authorized to do it on behalf of the organization. So the final number included in the data analysis was 65 total organizations. I bring this up now to caveat that this was one of the limitations of this survey, that we did have a smaller than expected sample size, but we do believe that there are a lot of really interesting things that did come out of the survey that we want to bring to your attention today. And I cannot see my screen, so if anybody raises their hand, if somebody could just let me know verbally, I would appreciate that.
Okay.
So we looked at the duration of palliative care that's being provided by the different organizations in Maryland as one of the survey questions. The organizations surveyed had various durations of operation, ranging from less than 1 year to 10 years or longer. Notably, there were 16 organizations that have been operating in the field of palliative care for more than 10 years. The longevity of these organizations is really interesting as it demonstrates their ability to navigate challenges and sustain their operations over time. We believe that these organizations that are the longstanding organizations, those of 10 plus years, could serve as role models, provide their expertise and experience to those that are getting started in palliative care, and share their wealth of knowledge to support best practices and improve the palliative care field. We also asked about how many members of a palliative care team were certified. Certification could come through various different options that we presented to the organizations, but based on the survey responses, we had that out of the 34 facilities that completed these questions, 27 reported having staff members who were either board certified, fellowship trained, or specially certified in hospice and palliative care. 6 of the organizations reported not having any certified staff members, while 1 facility was uncertain about their staff certification status. We see the presence of certified staff or fellowship trained staff as something that's crucial to ensure that patients receive knowledgeable and specialized care, and that we can know that facilities or programs that do not have certified staff members may experience potential variation in their training, which could impact the level of care that's being provided. Then we looked at how many services and consults are being provided by the different programs. So out of the 29 programs that responded to this question, 26 programs indicated they have or offer dedicated palliative care consultation services. We wanted to also know how often are these available. So this comes really into the context of what Peggy was just talking about with what NHPCO is doing and advocating for a new bill that's coming forth. We wanted to know how often that services are being offered or consultations are being offered. So when it comes to the availability of these services, out of the 27 organizations that provided information on availability, we saw that 23 of them had services available, basically your business hours, Monday through Friday, 9 to 5 at minimum. We did have a number of organizations that had 24/7 hour care, but most often it was the business hours of the week that palliative care services were available. We find that these findings highlight the commitment of these programs to make palliative care services readily available and accessible during the typical work week, which we do know is crucial for addressing the needs of patients in a timely manner. We're really encouraged to see the significant number of programs that do this and look to see where other programs may be able to enhance their opportunities to provide more palliative care, to help with care coordination, collaboration with other providers, and facilitate seamless patient care. So this is a really interesting slide. So I'm sure there's going to be questions on this slide because this was a little bit surprising to our data analysis team. So we wanted to compare the number of patients receiving palliative care services and consults in 2021 and 2022. We had a couple specific questions on this because we were very curious to understand if there were any changes over that time period coming out of COVID, going into a post-COVID era. So we asked the question about this to understand what services or how many services that they were providing. So this comparison between the number of patients receiving palliative care services in 2021 and 2022 shows some really notable patterns in terms of services. So if you look at the second and third columns, those are services. If you get to the fourth and fifth columns, those are consults. We wanted to put this all in one table so you could see how they compare. So in terms of services, there was an overall increase in patient numbers across all facility types. Home health and nursing homes experienced modest increases, while hospice programs had a significant decrease. Hospitals showed the highest increase in patient numbers. And then if you look at columns 4 and 5, again with consults, the trends were somewhat similar to services. There were increases in patient numbers for home health, hospitals, and nursing homes, although the changes were relatively small. However, hospice programs again saw a significant decrease in the number of patients receiving consults. So it's highlighted in red as something that we don't really have a clear understanding of why there was such a significant decrease in the number of hospice patients receiving palliative care. That changed from year over year. So more research would be needed to be done to uncover the factors that have contributed to this decline. I bring this up. Yes.
I just want to wait a minute. Did you have a question on that?
I mean, I think you asked me what I thought about the change. What I'm guessing is that, as we've been saying all along, that due to a lack of a revenue stream for palliative care services, you know, a lot of hospices just are not able to continue. Reggie, can you?
I would absolutely agree with that, especially during COVID and on the heels of COVID, when for many programs, hospice census has not fully bounced back. So if you don't have a full hospice census by which to basically cover your palliative care costs, your program is running in the negative.
Yes, I also think I mentioned in some of my comments that many of our hospice programs are providing palliative care services in various formats, but again, they're all running at a loss because many of these programs are being sustained or not sustained, let's say, by grants and philanthropy. So I think, we'd have to check with each program, but, I think that there could be something there.
Thank you. That's great. I know we've got your comments and I appreciate you adding to that. That's very helpful to kind of give a little bit more of a big picture clarification as to what's going on with the hospices themselves. Definitely something that we could look into a little bit more. We didn't collect any more granular level of data to get into that with the survey, but we can definitely talk a little bit further about how to best put that information together. Were there any other questions?
That's it right now.
Okay, perfect. Oh, sorry, I think I skipped a slide. I did. All right. So we did also ask about comparing kind of just in general from 2019 to 2022, palliative care services, consults, and referrals with some general buckets, if you will, of response options of do they provide more services, the same amount of services, or less services in 2022 than they did in 2019. So the majority of respondents that completed this question noted that they had an increase in the amount of palliative care services, consults, and referrals provided in 2022 compared to 2019. Out of the 27 respondents, 15 indicated an increase, 7 reported providing the same amount, and 2 mentioned providing fewer services in 2022. I will caveat that the 2 that mentioned they provided less services one noted that they were a brand new organization and weren't actually in operation in 2019, so there's a little bit of a disconnect there. We also wanted to understand more fully what are the most common palliative care services that are being provided when a patient is receiving palliative care. So from this chart, you can see that the most common palliative care services that were indicated by the respondents to these questions were first and foremost, patient and family meetings to support goals of palliative care. The second was pain and symptom management. And the third was advanced care planning. With close behind that, or not too far behind it, was communication and care coordination. We also asked some questions about what were the most common conditions or diagnoses seen by a palliative care program in 2022. So if you look at this big pie chart, it's a really interesting way to visualize this. We tried a couple different ways to put this into a graphic, but you can see that the majority or the top reason that a patient was receiving palliative care was because they had a diagnosis of cancer, followed by heart disease and then dementia, which dementia does include Alzheimer's disease. It was a general bucket list response, if you will, for this question. We also see that other topics or diagnoses that were included in this list included sepsis, failure to thrive, brain injuries, age-related infections, frailty, dying, wounds, aspiration, general decline, and generalized weakness. We do also see that sepsis is was a general or common theme throughout with a lot of the other healthcare conditions and issues related to aging and declining health. We looked to also see if there were any differences by facility and conditions or diagnosis. So across all types of healthcare facilities, the most common patient condition observed in palliative care programs in 2022 was cancer, as I mentioned. Stroke and dementia were also prevalent conditions across all facility types. We should note there were proportionally a lot more hospitals that responded to this question than other facility types, but these hospitals were more likely to report offering palliative care services for patients with all conditions listed here, except for the stem cell transplant patients. We also wanted to know what symptoms were being treated by palliative care. So we asked organizations, what were the most common symptoms that your organization sought to improve with palliative care services in 2022? And we asked them to list their top 3 most common symptoms. So you can see from this summary here that the most common symptom that was reported by all facility types was pain. This was reported as the top condition or as one of the top symptoms that was treated by 85% of the respondents, which really highlights its importance and significance as a symptom that's being treated by palliative care. Anxiety or nervousness and difficulty breathing were commonly reported symptoms across most facility types as well. We also saw that hospice programs had their top conditions were nausea or vomiting, depression or sadness, and pain. Hospitals prioritize symptoms such as anxiety or nervousness, difficulty breathing, and pain. And nursing homes or skilled rehabilitation facilities place emphasis on symptoms including depression or sadness, anxiety or nervousness, and pain. You can see the pain theme throughout all of them. We did also ask a question about pediatric palliative care. We know that most programs that we see or that we've researched have focused on the older adult patient population, but we do know that pediatric palliative care is a growing field. We wanted to understand if there were any programs that were currently offering a pediatric palliative care program or if they had any plans to develop one. Of those that responded, the vast majority did not have a program. There was 1 out of 27 that responded to the questions about pediatric palliative care that indicated that they had a palliative care program. This demonstrated to us the need to be able to do more to support developing pediatric palliative care programs in the state of Maryland, to work with our clinicians and our pediatric providers to provide palliative care to their patients to help alleviate symptoms, manage pain, and address the psychosocial and spiritual aspects of a child's well-being. This also emphasizes the importance of expanding training opportunities and resources in pediatric palliative care to ensure healthcare professionals are equipped with the knowledge and skills to deliver high-quality care to children with life-limiting conditions. We had talked a lot too about how is telehealth being used within palliative care or with palliative care. So we offered several questions on how telehealth may be used by a specific program or facility. So out of the 29 organizations who completed these questions on on telehealth, 9 programs reported utilizing telehealth services as part of their palliative care consultation service provisions. The usage of telehealth really did vary across different program types. Among the program types mentioned, hospitals have the highest number of programs utilizing telehealth, with 5 out of 22 hospitals incorporating telehealth into their palliative care consultation services. In contrast, both the home health program and nursing homes or skilled rehabilitation facilities reported not using telehealth for their palliative care consultations. I do want to mention that CAPC does offer a telehealth and palliative care toolkit and startup guide. I put the URL right at the bottom of the screen if you'd like to go and look up more information about what's being recommended by CAPC. I think that's another really great resource. I know we've had some good discussions with the team as well as within the work group about the potential of using telehealth. So I just want to provide you all another resource that might be of interest to take a look at. And I'm going to go through these probably a little bit quicker. I know I've only got about 5 minutes left in my allotment of time and lots to say. So we also wanted to focus on looking at some programs or some questions that were specifically focused at community-based programs. What we wanted to understand was if they were collecting any data or tracking any data on any specific topics currently. So what we found was that the data focused on what they were collecting, which included right now utilization or palliative care services utilization rates, mortality, patient quality of life, discharge locations, and other at this point. There was a few organizations that were tracking cost savings or cost avoidance practices, but very few. Within the hospital healthcare systems, we also asked an open-ended question about how are they doing quality improvement for their palliative care program. The survey highlights their responses, which focused on palliative care utilization, consultation numbers, and a few different outcomes. Some hospitals were also tracking patient quality of life indicators, which I found to be very interesting, as we know that quality of life enables hospitals to evaluate the effectiveness of their program, identify areas for improvement, and optimize resource allocation. Was there a question?
No question.
No hands raised, no questions.
Okay. We also wanted to understand what hospitals were doing to track any palliative care data collections, different things that they might be wanting to do to collect for different purposes for quality improvement or for internal purposes to understand referrals and things like that. So the most commonly tracked areas included palliative care consultations, palliative care services utilization rates, hospice referrals, and then mortality. A significant number of these hospitals also track data on hospice referrals, quality improvement, initiatives and service utilization. However, there were some areas that were less frequently tracked, such as hospital emergency department admission rates and patient quality of life. Oh, my notes. So this is just a little bit of an overview about quality improvement in a community-based program. So typically collecting and tracking data in community-based palliative care programs helps to evaluate program effectiveness, evidence-based best practices, and collaboration, which supports advocacy efforts, resource optimization, the delivery of high quality care. So I'm going to show you our next slide here, which is looking at, are there any other areas that are commonly tracked in palliative care community-based programs to understand what is happening with their patients or what's happening within their program. So they focused on utilization rates of services, mortality rates, hospital readmissions, and a few other metrics. I would say it's important to note that only 12 community-based programs responded to the specific questions, while we had about 14 that skipped this question, which were the hospitals, which are in that last column marked not applicable. But although the sample size is relatively small, we believe that the data collected from these community-based programs presents an interesting insights into tracking practices in the field of palliative care. So palliative care and quality measures, as you probably all know, are the way that the federal government is going with creating a value-based healthcare system. There are very few palliative care measures that are out there that are being implemented widely across different healthcare systems. So we wanted to go over and understand if any current hospitals, home health, nursing homes are doing or utilizing any quality metrics currently. So in order to gauge if any respondents were currently participating in any of these quality data care metrics, we asked what data they were collecting. We understood that some are utilizing national guidelines, monitoring and reducing unnecessary hospital readmissions, monitoring the number of completed advanced care directives and patient satisfaction surveys. These are the top areas of quality being monitored by the survey respondents. Of the respondents, it was also common to track the number of hospice referrals, monitor hospital readmissions, and some monitored advanced care directive completion and conducted patient satisfaction surveys on top of that. Several organizations are also doing their own research studies and data analyses to evaluate the impact of their palliative care programs in various aspects such as cost, quality, and patient satisfaction. These studies have focused on important areas, including the promotion of advanced directives, reducing emergency department visits, achieving cost savings, assessing quality of life, increasing hospice referrals, and examining the effects of early palliative care on length of stay and cost. Additionally, organizations have implemented data tracking at a team level and utilized tools like CRISP for pre and post analysis, as well as participated in initiatives such as the Uplift Grant. Through these analyses, organizations have been able to quantify cost savings, evaluate clinical quality metrics, monitor hospice referral patterns, and assess their impact on mortality rates. Around 50% of respondents reported engaging in quality improvement initiatives, which highlights a really interesting opportunity to promote the implementation of new QI programs. We asked a couple of questions too, just to understand better how palliative care services were being recorded in the medical record. So we asked a couple of questions about coding. So we asked if the or I wouldn't say it's commonly used, I would say if the Z code that could be used for palliative care was being used, which is Z51.5, and about 50% of the respondents indicated that they're using the Z code. If you're not familiar with Z codes currently are not reimbursable, but they can serve other purposes to help in quality improvement tracking, data analysis. We also asked about the CPT codes for advanced care planning, and we did find that the majority of the respondents are using the advanced care planning CPT codes. We did also ask several questions around advanced care planning. We found that the Maryland Order for Life-Sustaining Treatment, the MOLST, is the most offered form, with about 25 out of the, what was my N on that one? I don't have it written down, but I can look it up for you. 25 facilities that completed, that offered that MOLST form. It was also the most frequently used form and the form that was most often completed before someone started receiving palliative care. So 63% of those that responded to these questions reported that their patients consistently complete the most between 81 to 100% of the time. These are their palliative care patients, of course. We also understand that the Maryland Advanced Directive document is quite often completed. The Living Will, the Maryland Advanced Directive translated into Spanish, and several other forms are completed less often. So then we had, these are my favorite questions because I love hearing directly from the survey respondents, their stories. What's working well in their program, what's not working so well in their program, where are they being challenged, and what advice would they have for us to be able to educate patients, families, providers on palliative care in Maryland. So this specific question asks about the strengths and key enablers of high quality palliative care programs. So from the perspective of the respondents, they felt that a strong and dedicated team that was committed to personalized patient-centered care was a really strong predictor of having a successful palliative care team. There's 8 different things in here. I would encourage you to take a look. They're all very interesting, probably relevant to what you've read in the literature, but really focusing how we have an interactive, supportive leadership team that's working together in a partnership to move forward palliative care as really the basis for having success.
Rebecca, is there any
Yes.
meaning to the coding on the little boxes?
Can you, I'm sorry, I can't hear you.
Is there any meaning to the color coding on the cubes here? Some are red, some are yellow, some are blue.
There is no meaning other than it looks good.
Okay,
Good question, Ben. So as I mentioned, we did also ask about the challenges and barriers that palliative care programs are experiencing. As we all know, and as Peggy had mentioned earlier, some of the challenges are financial. Finding appropriate reimbursement models that can support a palliative care program are a real source of stress for these programs. Similar to what we're seeing in a lot of the healthcare fields, staffing and resource allocation are always issues. Having enough staff to support the program, having enough highly trained staff that are educated and have the ability to step in to be part of a palliative care team. Interestingly, we saw this in a couple of different places, but the perception of what palliative care is and is not came up several times. In the sense of it's an area that is a challenge that if you are part of a palliative care team, it's oftentimes an unknown quantity, if you will, to others that work outside of palliative care. So having to explain what palliative care is to your colleagues, as well as understanding how you explain what palliative care is to patients and differentiating that from hospice care was something that was of concern. That ties right into the palliative care education where the respondents felt, I think it's oh gosh, what number is it down there? It's on here where, it's the very last one, alleviating misconceptions about palliative care to enable individuals to better navigate complex and critical illnesses while receiving appropriate support. Other areas of education they felt would be really helpful for both patients, the public, family caregivers, and providers is focused on promoting early referrals to enhance access to palliative care services, utilizing diverse educational resources to educate the public about what is palliative care services, where they can go for more information, using pamphlets, websites, handouts, and webinars to be able to do that effectively. And then for providers themselves, providing ongoing education for the healthcare providers, as well as the discharge planners to ensure that consistent and accurate messaging is being provided to patients when they're leaving a facility or a program or transitioning to another program to help with care coordination. And then additionally, they highlighted the need to really do better to serve our underserved communities to address disparities in access and awareness as to what is palliative care. So doing targeted educational efforts focused on those underserved communities. And lastly, really creating a more transparent and coordinated education system to be able to partner with patients and families to help them make those informed decision makings, to help them with shared decision making so they really can make an educated choice about what they want to be able to do with their care moving forward, if palliative care is the right fit for them or not. So I've gone through a lot here. I acknowledge that. The survey was long. As I mentioned, we do have some recommendations that we'll talk about in just a couple of minutes here about how we could improve the survey in the future. We would definitely recommend the survey be done again, but in a more targeted fashion to gather very specific information that is needed to help progress with new legislation or support new initiatives that might be coming forward in Maryland. But I'll open the floor for any questions, and I can stop sharing, then I can see faces again too.
Thank you, Rebecca. I have one question that did come up in the commissioner presentation, and that is, we did lose. Can you hear me?
Yeah, it's really muffled, so I'm sorry. I'm trying to lean into my computer.
So I will use my shouting voice. The fact that we lost about 2/3 of the respondents because they didn't meet the definition of CAPC did raise questions. Did you look at any of the responses that on your first slide, you show 117 that were excluded? Did you look at any of the responses from that group? I assume that most of them completed the survey. And if you did look, what could you say about that? Did these responses differ? Or
that's a really good question, Ben. That was something that we were definitely concerned with. So we had two qualifying questions, if you will. One was, do you meet the CAPC definition? The second question was, are you authorized to respond on behalf of your organization? Part of the issue with the difference in respondents is, first and foremost, like a lot of the home health organizations did not meet the definition because they didn't technically provide palliative care according to the palliative care or the CAPC definition at all. There was one that said they did out of all of those home health organizations. We also had an issue with those that were included versus those that were not included. There's just a lack of responsiveness on the behalf of some of the organizations to follow up and complete the survey. So some of the organizations entered their demographic data, but never actually came back and finished the full survey itself, despite a half dozen to a dozen follow-up phone calls, emails, short of showing up in person and demanding something. I don't know if we would have gotten a response from them. So we lost those because we didn't have any data other than to say we know whether or not they assert that they are a palliative care providing organization according to the CAPC. The other organizations, why they dropped out, just differentiate them. We don't have any other additional data. We just asked those two qualifying questions based off of the Colorado survey that this web-based survey was off of. So I don't know if there's anything else that would differentiate them from others that did respond. I feel like we do have palliative care programs that responded that are very representative of other programs in the state. It's limitation though.
So I think one of the things that was surprising to our commissioners were that by definition, a hospice provider would meet the definition of delivering palliative care, but it looks like about half of the hospice entities were excluded, and
not all hospices are doing palliative care.
Right.
All palliative
but if
care is hospice, not all hospice is palliative care.
If we believe that, well, I'd like to hear what Rebecca says here.
Well, I think what Linda was trying to say is all hospice care is palliative care, but not all palliative care is hospice care. In the sense of, I know this was a question brought by the commissioners that palliative care can be offered for somebody who doesn't have a terminal disease. It can be offered for somebody that's curative. You know, palliative care is for a patient with serious illness. So the questions that we utilized were those that left it up to the organization to decide whether or not their organization met the definition, the CAPC definition. So if they felt they did not meet it, they checked the no box.
Can I clarify on that?
Okay, yeah, I was going to ask representatives in the room to comment on that, because that is a startling
Yeah,
That's all.
so my comment on that, let's be clear about the definition of what hospice care is and what palliative care is. So correctly, we have said all hospice care is palliative care, but not all palliative care is hospice care. And why? Why is that? Because when you are receiving palliative care, you can also receive curative treatment. And I think that's where the biggest difference is.
And you're not required to have a limited prognosis.
Exactly.
Right. So there are numbers of hospices. Yes, they're providing palliative care, but they're providing palliative care to individuals who they believe have a prognosis of 6 months or less. So.
And not all hospice providers consider themselves as offering palliative care services. They only do that if they will admit patients who are still receiving curative care without the prognosis of a terminal illness.
We asked that on the survey as well.
So that there is a real clear distinction there.
So Rebecca, I just wanted to clarify, there are actually then 3 criteria for who's excluded. 1 is not meeting the definition, 2 is not being authorized, but 3 would be did not complete the whole survey.
Yeah, that's more of on a case-by-case basis. It's not like a clear rule. Yes, you're right. You're correct, Linda.
All right, you have a question on here?
It's Monica.
Okay, Monica?
Go ahead, Monica, if you want to.
Yes, can you hear me?
Yes.
Okay, thank you. Coastal Hospice is one of the hospices that was included in the survey as we meet the CAPC definition and have completed the whole survey. And I can tell you that each hospice palliative care program is different. And it's due to the low and poor reimbursement rates that we have to live up to. You have to understand that it's not only that Medicare and Medicaid that pay us poorly, but the commercial insurances are even worse. So it's very complicated. And the billing, the other problem is the electronic medical record. There's not one electronic medical record that will allow us to do a good job. We are very privileged in the fact that we have a strong partnership with Tidal Health, our largest hospital here, and we use their EMR to do the billing for our palliative care visits, which is Epic, which is the Cadillac of all the EMRs in the nation. So we have good data and we have good billing, and still it's really not good enough, the reimbursement. But in addition to that, I wanted to bring to your attention the issue of the MOLST. And Rebecca, you mentioned that the MOLST are filled up with every palliative care consult. There's a caveat to that, because every time a patient goes back to the hospital, they have to complete a new MOLST. So the issues that we see with those MOLST is sometimes the old MOLST is lost. And then there's a new MOLST, and the patient, in some cases, the patients don't want to be reminded that they have to forgo all these treatments over and over and over again. And that sort of hinders the ability of these palliative care consults to be focused on the issues that are really important to the family. These constant requirement to do a new MOLST every consult, they have to do it, but it takes time and it's aggravating to the families that have already completed one. So I just thought it would be good to bring that to your attention. Thank you so much.
Thank you.
Thanks, Monica. Are there any other questions?
No.
Okay.
I had one other question. And that's Rebecca, the slide that you had on most common symptoms by facility. Just in terms of the hospice programs, I was speculating, and hospice representatives, including, of course, both those on the phone, on the call and in the room here, it seemed like those symptoms would be commonplace for hospice patients. While the survey was intending to get the entire spectrum of conditions over the course of a palliative care, episode, is there any way to distinguish a palliative care episode where curative care is continuing versus true hospital care. It just didn't look like there was any difference in terms of what might, if we asked the same question, the hospice programs in their treatment of hospice patients, what were the symptoms they addressed? I would be surprised if nausea and vomiting, depression, sadness, and fatigue would not be the same ones that hospice patients reported on. And so how do we get, drill down a little further and see it on this broader range of palliative care? What are the spectrum of services that are, or symptoms that are being treated? It didn't look clear to me.
So Ben, if I could just respond to how I answered the survey for my program. Basically I did not look at data from my hospice patients. I looked at data specifically from those patients who were in my palliative care, under my palliative care wing, both community-based and in the hospital setting. So I didn't include hospice patients in my diagnoses or my symptoms or any of the other questions.
Thanks, Reggie. Anyone else want to weigh in on that question?
I don't know if Rebecca was, I think, responding.
Rebecca.
So as you probably saw, I'm not showing my screen, but we didn't have a way to distinguish whether or not the palliative care services were being provided for someone with a curative disease or a non-curative disease in the sense of what their exact diagnoses were. We just simply asked what were the most common symptoms that your organization sought to improve with palliative care services specifically in 2022. So we don't have that definition. And then we used the symptoms that were most common and recommended by CAPC for inclusion in the list of symptoms.
Thank you. Other questions from those people who have dialed in remote?
Dr. Kearney, briefly, I don't have my chat button, but I just wanted to comment to Rebecca. I think generally this survey does reflect fairly accurately what is going on in palliative care. It's a small survey. I'm sure you'll do better with more, but all of the themes are extremely common to me as a 15-year palliative care physician. You've hit on pretty much everything. So I appreciate what you've done. I certainly encourage the next round and to reach deeper, but you have identified in general most of the important features. So thank you.
Thank you.
What better accolade than from someone who's been in the industry for 20 years or 30 years, a long time. Let's now see.
Monica has her hand raised.
Yes,
Monica,
sorry, I'm here again just to agree with Reggie and what she said, but I am concerned that the data could be tainted by some of the indicators being used from a hospice program and not the palliative. I think that would really skew the findings significantly, because if hospice is understood that the hospices were the palliative care programs, then those of us who are struggling to keep alive our palliative care programs, it is a very different situation. And for Coastal, we have a different palliative care team that is not the hospice team. And Reggie, I assume you have that as well. So you can speak to how confusing that can be if the data has that in it.
Actually, not so confusing for me, because to your point earlier, Monica, the challenges of an electronic medical record. So my hospice patients are on a totally different electronic medical record than my palliative patients.
Yeah, same with me, but sort of other programs may not have it as clear as we do.
Correct.
I understand.
Yeah. Thank you.
So I think recognizing we are at, we're a little bit behind. Linda, what are we doing next?
Okay, before I move on, we're going to move on. I neglected at the beginning of the meeting to ask, we had a summary of the meeting from May 23rd, and I just wanted to check to see if there were any corrections, comments, or updates. Do you have? I believe Dr. Boland had a comment.
Yes, hi, good afternoon, everyone. I just wanted to make a comment. in the minutes that the pilot program that Care First has been conducting with MedStar over the last few years, it said in the minutes, I believe, that it had ended, but it has not ended. So they were still looking at the data and just evaluating that. So I just wanted to just clarify that.
And,
thank you.
And that's a hospital or a community base?
So that is a hospital. Yes, thank you for bringing up. It is a hospital base. So, you know, the initiation of the palliative care hospice is once the member is admitted to the hospital. Now, I don't, you know, there's a possibility they may certainly go and look at it, and after getting and pulling their data together with this pilot, is looking out to maybe incorporate that into the community base and getting that out there, you know, initiating in the community before they get to the hospital.
Okay, because I believe the comment that Dr. Kearney made dealt with a previous earlier pilot that Care First had done that was involved with the community. I believe that's what was cited, but we can add that to the meeting.
Linda, briefly, I'm not familiar right now with the MedStar version as I'm retired from there, but the original project included both hospital, identifying the patients in hospital often, but then following them in the community. And the benefit was clearly to prevent readmissions, ED visits, et cetera. So I'm not sure how it stands now, but it was certainly going to be, the idea would be comprehensive. For Care First, that would be what would be helpful, I'm sure.
Yeah. Yeah, I agree with you, Dr. Good. That's basically, if I wasn't clear, that's basically what the pilot was doing, is identifying them in the hospital, continuing in the community, but the initiative was not in the community first. So it's looking at it a little differently.
I'm from MedStar. Hi, Chris. This is Rachel Adams. Can you just reframe your question? Sorry, I was doing something else, but I hear a question about the pilot.
Yes, it's the pilot Care First MedStar, and I'm not involved in that pilot, but
I am. Yeah, no, it's our program. So what is it? Question?
The question I think maybe right now, the initial the pilot was geared towards identifying the patient in the hospital and then continuing the palliative care, hospice care outside the hospital setting. But no,
it's only
comment more fully.
Yeah, no, it's the pilot of what we've done to date with Care First has just been for an inpatient hospitalization. There are cases where, you know, we're able to connect them with outpatient resources, but Care First isn't involved in that piece of it. And not all of the patients are in an area where there's outpatient palliative care to provide them. So yes, I mean, as with any of the palliative care consults, like the Care First pilot, what the Care First pilot really did that I think is important is it gives us a certain amount of money for each patient that funds the whole interprofessional team. So we get a bundled payment for an inpatient admission as opposed to just the regular fee for service. So it's actually funding, in a way, it's kind of funding the full interprofessional team as opposed to just you know, just the RVUs you're going to collect off of MD or NP billing. But it may in the future have connect points with outpatient. It doesn't currently.
Okay, thank you for that clarification. Okay, so moving on in the agenda, we also included in the mailing a summary of 12 selected states and their efforts in palliative care, including legislation, education, funding, quality, and data collection. We're not going to go through these in detail, but they serve as a reference and background as we work on the development of recommendations. So just wanted to clarify that. How do I get back to this? Here. You control it, yeah. Yeah, that way. To the slides.
Whiteboards.
Oh. Are the PowerPoint are the slides on PowerPoint, or are they loaded someplace?
They're loaded.
There you go.
There they are.
And share.
Okay. So we want to focus the rest of the meeting on reviewing the draft recommendations.
Slides. You have to share
your screen. Yes.
go to where it says, okay, go pull that back. Yeah. Wait, you want to
share your screen.
green one. Share screen. There. Okay, now pull up the slide. Hit the slide.
Let's see, is this the slide deck?
Yes. Yes.
It's hard to share. I with my left hand here. I didn't realize that. Okay.
Now get the side off because you don't need that.
All right, we're getting there. We can move along on the slides anyway.
Well, you don't want the side.
Yep. Top where it says slideshow, and then click on up to the top slideshow. See the menu item slideshow.
No.
At the top, slideshow. Yes. You see where it said the menu item that says slideshow?
Yeah, we can't see it because we're.
No, it's covered up.
Yeah.
On the key.
But just take on the top button and slide it to the side.
Press F5 on the keyboard.
Okay, thank you.
Thank you.
Okay, I didn't know that. So anyway, moving along to the draft recommendations. The mailing we sent you is a list of draft recommendations, and as Ben noted, these are draft. They're really just the first step in the process, and the interim report is not going to include the recommendations. It's going to focus on the process, legislation, the work group, the data collection. So we've just included the same recommendations that you received in the mailing and just copied them here by subject for ease of recommendation. So discussion. So the first is public and provider education, and just to invite any comments on these, either as is, recommendations, changing. We have comments.
Just slide it, bring it down, right?
Okay.
Okay.
I think.
Thank you, Tracy.
You're welcome. Thanks. Are there any comments, questions?
So as is our practice at MHCC work group meetings, we sometimes call on people if we don't get any comments. Before I do that, I wanted to encourage people to comment if they had any thoughts.
And I just want to say these are very expansive. Many of these are beyond the range of what the commission can do. They can be recommendations broader to the legislative bodies, but
or to sister agencies, as you'll see shortly.
So if there are no comments, it must be perfect.
Well, I wouldn't go that far. I think some time to contemplate this. Let's move to section B, the public awareness and education.
Okay. The second one, seek funding to launch public awareness campaigns to educate individuals about the benefits and importance of palliative care, collaborate with community organizations, patient advocacy groups, faith-based organizations to disseminate materials and host public forums on palliative care. We did send this out in the mail.
We are, and Linda, this is a directive to state agencies, or this is directive to associations. This is a directive to healthcare providers. Who is this? The who is not clear to see.
I can give a little background on where this came from. It's actually looking, if you look at the other document that we provided from the other 12 states, there are a lot of states that have public education campaigns, which are geared at the public, which would be patients and families, to educate them on the importance of palliative care, what it is, how they can learn more, all of that information. There are various different collaboratives, coalitions, various different state-funded websites and other different avenues for dissemination of information that are made available to really promote and educate the general public.
I do have a comment about this recommendation. While I think it's a great recommendation, I guess my only concern is that we have just identified the fact basically that we don't have enough palliative care providers. And what we do have isn't well funding. So what happens when we start making a huge public awareness campaign and then all of a sudden people are like, oh, I love this idea, and there's nowhere to go. So maybe that's something we'll want to talk about a little bit further.
I think once we go through the whole package and maybe they can be prioritized.
Prioritized, okay.
Or, you know, staged at different times. Sure. But I think the other field recommendations kind of deal with the rest of
a question for Rebecca then, in other states who have been the funders. Can you characterize that?
Who's funding the different initiatives? It really depends. So some states actually fund it through, like if you look at what California is doing with Medi-Cal, they fund it through their state initiative. They fund a lot of education. They mandate palliative care services that are provided to all of their recipients or their beneficiaries. If you look at other states, they have philanthropic organizations that are funding some of the public awareness campaigns. So it really does depend. And this could be something where we could recommend potentially to the state to launch a public education campaign, put more information available on the website. There's some specific other recommendations that deal with having more information publicly available on state websites, as well as there could be a collaborative that could be a partnership with a grant funding organization. Really just kind of wanted to get everybody's feedback about in general. I see there's some comments coming through the chat, so I appreciate that. Just to see what you initially thought, and then we can kind of finesse these and make them smart recommendations. And if everybody knows what smart recommendations are, look at making these recommendations into those, and as Linda just said, prioritizing them. We realize the state has limited resources. We want to use them wisely to have the greatest impact.
Anything else in the chat?
Shirley has comment. So I can
just read it.
I'm wondering if a coordinated public awareness campaign might be the most effective, as every state organization discipline has this need. And keep in mind that professional, in quotes, awareness education is also needed. As your date indicated, there's a great deal of confusion within healthcare about what palliative care is. And then lobbying for feature?
Yeah, that's a federal bill.
Right, and funding for education through that mechanism might also be of use. Data.
Thank you. Thank you, Shirley. Thank you, Tracy.
Maybe we can.
Let's move ahead.
This one should be a bit easier. Partnering with the Maryland State Advisory Council on Quality Care and Life, as Dr. Kearney mentioned in a previous meeting, trying to collaborate on public education efforts. Okay. I don't know if Dr. Kearney's there still.
Okay,
He's there.
Hearing no comments.
He has to unmute.
Let's
I'm sorry, am I unmuted now?
You are unmuted.
Sorry. Difficult. I'm briefly on the other part. Most of those recommendations are areas that are not new to anyone in palliative care. Many of those efforts are actually ongoing in different ways in the state of Maryland. So the idea of launching, to me, may overlook what a lot of the work that's being done, identifying who is already doing some of these things are recommended and coordinating them makes more sense to me. As far as the Council for Aging, this is a major topic on our council meetings regularly. This meeting I report on regularly. So the council is very anxious actually to be part of this endeavor, and thinking that the palliative care survey and whatever recommendations come out of it formally would be something we'd be very interested in being a part of or supporting in any way we can as the Council on Quality of Care at End of Life.
Great, thank you. Okay, and as we move into the funding efforts, as we know from other states, many of these affect the Medicaid program. As Ben has mentioned, this is still being reviewed by the Maryland Medicaid program, and we're waiting for comments from them, so we can't commit to any of these, but we can discuss the range of possibilities. And this is for 1915C waiver for home and community-based services, not hospital services. And it's not clear to me whether it's just integrated into existing waivers or if a separate waiver request is needed to, I don't know how it's been implemented in other states. This is also something that Nashby may have some background on based on other states.
Yeah, there's a great Nashby report we can share too with the group that kind of goes through what other states have done to integrate more fully palliative care into their Medicaid programs. Some of that is in that list of 12 states, but there is also I'm blanking on the title of the report that we can share.
Yeah. Right. And how would you characterize what is integration of palliative care services within a home and community-based program? How would that actually work? I think
so what other states have done is it's a recognized reimbursed service as part of their Medicaid waiver. So it's specifically called out. I believe it, trying to remember all the data off the top of my head, it really differentiates on how they do it. Hawaii has a really, a lot of new legislation that's come out of Hawaii, and New Jersey has some new legislation coming out. I know that Peggy just sent to the team a little bit earlier. But they're doing it in various different ways, but it's calling it out more specifically versus just assuming it's part of like other long-term care services.
Maybe I can add to that. This is Monica. For instance, in California, Medi-Cal offers a palliative care benefit that pays a fee per member per month. And that allows the palliative care providers to monitor the care, to have an interdisciplinary approach to the care. And the results are amazing because those patients are not caught in the revolving door of the hospital visits, because the reimbursement allows for that. And it's an initial assessment reimbursement. And then there's a per month. So you can also offer on-call services, because you prescribe medications that are providing treatment to the patients, right? Their symptoms are being managed. They are able to do things they couldn't do before. The symptoms are mostly side effects of treatments they are undergoing or conditions they have. So suddenly the patients are doing better, but not all. Let's say there's a problem with a medication. Who do they call in the middle of the night? The current reimbursement model that only pays you per visit doesn't allow for providers to have on-call physicians available to be responsive for situations that happen after hours. That's a big hindrance to expansion of the programs. If we had a fee per participant per month, it would be different, and we can serve a larger portion of the population. And this is particularly crucial for rural areas. So I encourage everybody to learn more about Medi-Cal, because they are, I think, one of the best models right now. Thank you.
And Monica, thank you. The question, when you talk about a PM payment, you're talking about the universe would be participants in the Medi-Cal's home and community-based services program, not the entire Medicaid population.
No,
or is it a different subset of that?
Exactly. It would be those who are eligible for palliative care, and they would enroll in this program, and the palliative care program would be responsible for monitoring their care.
Okay, thank you.
Perfect. You want me to
Move along.
Okay.
This is Cindy. I have a question on this.
Yes.
Right now, the home-based waiver system is backed up with many, many people waiting and can't get the services. So how are we going to be able to, if we get people for palliative care in that, how are we going to address the fact that they sign up, but they can't get it? Because the waiting list is thousands of people.
Yeah, this is why this is something that Medicaid has to review and agree to pursue and get funding.
Yeah, I think Linda answered the question.
Okay.
Certainly Medicaid is aware of the lengthy wait list for this program and has recently taken steps to, I think, expand it in certain additional jurisdictions. But yeah, the wait list is something that our colleagues at Medicaid are very well aware of, and I think understand that additional funding would be needed to meet the demand that exists for the program.
Thank you, Cindy. So this one gets into both Medicaid managed care and the total cost of care model in Maryland. First is ensuring that palliative care specialists are included in the Maryland Medicaid managed care networks. Again, this is something for Medicaid to review. And then supporting specialty palliative care teams through the total cost of care. And I don't know to what extent anything that's been done on this post-acute portion of specialty care.
Yeah, this has not, that I'm aware of, been discussed as an option. I mean, I think clearly this would be a feature that public and private payers would have to offer, and it would make the most sense to implement it in that fashion. Although one might argue that health systems had a special interest in also looking at avenues for funding palliative care units. I see Aaron Davis is on the call. Aaron, do you have any comments?
I think I would just say that, you know, we're at a point where we're looking at what the next iteration of the model is going to be, and, you know, support for people with serious illness and end-of-life care is something that is definitely being considered in progression planning. So I would agree there's opportunity there.
And Matt Celentano, I saw you on earlier. Are you aware of any ideas moving through the payer community? I think we already know about their first pilot with MedStar, but any other initiatives that would meet certain aspects of this recommendation?
Nothing that's been immediately passed on to me, but I've sent this back out looking for feedback, and as soon as I get it, I'll pass it along.
Thank you.
Any other comments?
Yeah, I mean, I think in terms of both of these, they do, the who is something that as we perfect these, we want to, we have the what, and I think we have the how, but you know, who is going to take this on is a question, both from the standpoint of Medicaid and as well as the broader provider payer community, if we want to talk about it being a feature of the total cost of care model. Let's jump to the next one.
Okay, this is more of the same. Medicaid. Maryland is not included in the states with Medicaid managed long-term care services and support. So this is considering implementing Medicaid managed care services and supports for older adults.
I know we have a Medicaid representative on
Joanna
Ruth, and you know, has this ever been considered of actually applying to participate in managed long-term care services support program?
I can take back to my folks whether that's been a significant consideration. I know obviously right now it's fee for service, but I can take that back to Tricia.
Thanks a lot.
And do you have any comments on any of the others, since several of these involve Medicaid?
A lot of these recommendations sort of tag in varying directors from varying pieces of Medicaid that I just want to make sure that I get their feedback before weighing in.
Yeah, okay. Thank you. Thank you.
And this is the dual eligible special needs plans incorporating care manager training and assessment for palliative care and palliative care providers into these networks.
Yeah, and for those that are not familiar with these SNPs, we're talking about Medicare Advantage products here, correct, Rebecca? And there are a couple of SNP providers in the state of Maryland, including Care First is one I'm aware of.
I think there are 4 or 5 at this point.
Anyone from a perspective of a SNP want to weigh in on this?
No.
Just a question for Rebecca. Would this be something that would be updated as part of the annual competition for Medicare Advantage participation, or certainly simply adding it in the midst of a once the program is established and rates are agreed upon, would seem to be hard. Do you know how other in other states?
Yeah, I just dropped, good question, Ben. So I just dropped what California has done with their Medi-Cal program. I dropped the link into the chat. So this is something that requires their managed care plans to have palliative care programs for members. The dual eligible is required for palliative care programs for the dually eligible members, and the guidance that they have provided is available from that link. I think they're the only state, don't quote me on that. I'm just looking through my list again. There's only California, and there's I think at least one other state that does have this program. I'm just trying to find it there. It's in the summary there.
So it's a Medicaid fund, or in California.
It's a policy, yeah. So it's a policy for how they manage it. It includes typically care coordination around the provision of palliative care, including guidance around eligibility, provider settings, and services.
And is that part of the Medi-Cal program, or is it part of the Medicare Advantage?
It is part of the Medi-Cal managed care plans.
Okay. All right. That's helpful. Yeah, I was uncertain how that could be rolled into a Medicare Advantage product that tends to be, defined in scope and coverage rules nationally. Okay, thanks.
Okay, so this is patient-centered medical homes, which I guess you said is MD PCP in Maryland.
Correct.
And so this again is enhancing it by embedding palliative care training and strengthen it by providing training to prescribe and client clinicians on effective pain management and palliative care needs. This is training that would be added to patient-centered medical home.
Yeah.
Model.
And I mean, there's a appropriate, I could speak a little bit about the who that potentially could do this, which would be both the state maintains a support arm to the MDPCP, which is the program management office for the program, staffed by state employees, not government. As part of that initiative, care management organizations support MDPCP primary care practices that they would potentially have some capabilities to provide to primary care practices that are signed up for that care management organization board. I don't believe this issue has been discussed with certainly with the project program management office, but with the care management care transformation organizations. Either those largely are health systems, although there are a couple other types of entities, including ACO type support entities that would have the capability, I think, to provide training on accessing palliative care, although I doubt that they would be directly providing palliative care themselves. But that's something that we would want our colleagues at the MDPCP Program Management Office to weigh in on, as well as the CTOs, Care Transformation Organizations. I would note that we have previously discussed the work that Palliative, a entity that participates both in the MDPCP program and is also an ACO nationally, that they have actually acquired a palliative care entity, Iris Care, demonstrating in one situation, I think, that the delivery of palliative care services are unique and specific and are better advocated or advised on by palliative care experts as opposed to care providers that are involved in curative treatment. I think it's been somewhat successful for Palliative. It's only been, the acquisition occurred about a year ago. So the integration is still ongoing, but it does seem like a promising approach to making palliative care more readily available and explained by experts in the field. I don't know if either of our hospice representatives here in the room have had any engagement with Iris Care, but it is a now fully owned subsidiary of Palliative ACO.
I have had exposure. This is Monica. Some of our primary care physicians are part of the Allendale affiliation. They provide their electronic medical record and other things. And what I have seen they are doing in the primary care practices is write an algorithm that triggers the discussion about advanced directives, and it's tied up to palliative care consults. And they are done remotely by other providers. But here in the Eastern Shore, I have to tell you, I know about this because this particular doctor invited us to come to their office, and he said, I don't know that there will be many of our patients wanting to do remote here. They want to see someone in person. They want to know that they're talking to someone who knows the community, who is part of the community. So he reported that to me more as a concern that it would be better for him to have Coastal Hospice come and have on-site those discussions rather than having them in that way. Trust is such an important commodity in our community that he was very afraid that the patients would be intimidated by someone deciding that advanced care planning is such crucial decisions about their end of their lives that he felt having them casually on Zoom or some device, it would not be good for most of his patients. So while I think it's a great idea and having the algorithm that triggers these kinds of consults, I think the implementation and having, especially in rural areas, a trusted source is really, it's going to work better. I also want to reinforce this comment that was made before by Peggy, that it's not lack of education. I think people need to sort of understand what palliative care can bring, but it's more that we need to build the muscle to provide those resources before we go out educating and creating demand for a service that we might not have the capabilities to offer yet. So I think if we have limited resources, they are better spent helping us have more robust palliative care programs, and then it can be some more education would be beneficial. But as far as I know, people do understand, especially the providers, what palliative care is in this area. Thank you.
Thank you.
Other comments?
Rebecca.
Rebecca?
Just a side note that I added clarification on DNSPs and MLTSSs directly from the report that we're writing. So you have the exact language that we're putting currently into the report as background information. That information's in there. I also did add the summary, Ben, about Alidate and Iris Health that we have in the interim report currently, just as an FYI.
Oh, thank you.
Thank you.
And anyone can see that by clicking on the chat if you're online. You'll have to take our word for it if you're in person.
I'll take your word for it.
Okay. The next one is, again, Medicaid. I think this is the last one that we're hitting Medicaid with. Medicaid health homes, and using that as a platform, basically for ongoing care and support for individuals with serious chronic conditions, and then incorporating targeted consultations with palliative care specialists as part of the screening process for patients and caregivers within Medicaid health homes. Have any questions?
I don't see any questions or hands raised here. Again, the same qualification on as was made earlier is that Medicaid leadership is still reviewing these recommendations, and keep in mind that a lot of these recommendations have a cost or a programmatic requirement, a waiver. A state health plan amendment, a waiver application. So saying it doesn't make it so, we need to keep that in mind.
All right, moving on to broader. This is kind of a broader community-based palliative care in general. Prioritize the expansion of home and community-based palliative care services in Maryland to improve accessibility and convenience for patients. Explore innovative funding models, including contracted alternative payment arrangements and financial subsidies to provide stability and flexibility for palliative care programs, and encourage the expansion of community-based palliative care programs in hospices and home health agencies. So these are not directed to a specific organization and are more global.
Yeah, I mean, some of the first recommendation, might overlap with what we are encouraging with MDPCP and Medicaid health homes, but I think it more broadly states the same preference or directive, I think.
Any comments, questions? Okay.
I mean, I do want to go back to what Peggy said earlier, that encourage expansion in hospices and home health, that this has to be qualified based on, there also has to be a funding mechanism in order for this to work. But I see, did you have a comment, Peggy?
I did. No, I don't even know if this is the appropriate place for it, but Ben, I totally agree. I think you were really on the right path there too with your comments. I just wanted to add to that, you know, if you all recall back when we passed legislation for the inpatient-based palliative care services, we also reconvened and met up to talk about some standards, best practices, quality measures, if you will. I really hope that however we decide to move forward, that really that will be our next work group. I think that's so important that we develop some kind of standards for this particular type of care, as well as some really good quality measures so that we can look at the outcomes. So that's just kind of my comment.
We do have some recommendations on
for that. Okay. Is that later? Did I miss that? Sorry.
We have a lot of recommendations, draft recommendations. Some may go bye-bye, but go ahead.
Yeah. All right.
Monica, you have your hand raised, Monica?
She doesn't have her hand raised. She had a comment in the chat.
All right, it's in the chat. We'll review it.
Put a comment in the chat because I'm talking too much.
Monica did say community-based palliative care is critical in rural areas. Please consider that recommendation. I guess you're saying a specific call out to rural areas.
Yes.
Suggesting. We hear you.
Thank you.
These are addressing, I mean, everyone has mentioned the shortage of staff. So it's kind of what do you need first, but these are trying to address the impending workforce valley and ensure adequate access to specialized palliative care. It's recommended policies and payment reforms be implemented to promote the growth and sustainability of the specialty palliative care workforce and encourage the establishment of interdisciplinary palliative care teams with required core disciplines and this refers to CAPC guidelines. So these are general workforce development. Again, doesn't get into who is doing them or how as much as the need for moving forward.
Okay. Again, you know, I think as we think about this, we have to think about how these are high-performing interdisciplinary palliative care teams are going to be paid. Rebecca, you have a comment?
It just cited the statistic from CAPC from the state-by-state report showing that there are approximately 3.1 providers for palliative care per 100,000 residents in the state of Maryland, and that is inadequate to meet the growing demands for palliative care in our state. And then just to add to that, Maryland currently only has 2 accredited fellowship programs for hospice and palliative care medicine. One is offered by Johns Hopkins and one's offered by MedStar Washington Hospital Center. So it's definitely a need. How you operationalize that will be.
That's the tricky part.
Tricky, yes, that's the right way to put it.
Okay. Thanks, Rebecca. Anything else on that? All right.
Yeah, and of course, you know, I think keep in mind that you know, Hopkins vision is global, and you know those Hopkins trained providers are unlikely or less likely. I shouldn't say unlikely, less likely to actually practice in the state once they complete their training. So
Shirley has a comment.
Shirley, you had a comment?
You can read it. It's in the chat.
That's in the chat.
Yeah, the real challenge is determining incentives to encourage professionals to seek additional training when currently many are already feeling overworked and burned out.
Yep, it's the challenge. All right, Peggy, this is for you.
Thank you.
See, we heard you and immediately developed recommendations. But anyway, basically strengthening palliative care quality improvement efforts. And then there were some specifics in terms of developing a quality improvement framework and encouraging increased participation and accountability in palliative care quality improvement initiatives. Rebecca mentioned many of those that are going on in both hospitals and community-based programs based on the survey. So again, building upon that and trying to reinforce it.
One thing to look at is in the state report is what Hawaii is doing. So they've created a quality and data collection and palliative care program that is really kind of setting the bar for what's possible in creating a quality improvement framework within a state that's directed by the state. So I would encourage you to look at that as something that we could potentially use as a jump off point, if you will, for what might be possible to develop in Maryland. There are also many other states that are focusing on, because we're in a value-based healthcare system right now, how they can develop and measure the quality of care that's being provided in palliative care to show the return on investment, how it does reduce costs and improve quality overall.
Thank you. Do you have a comment on this? Anything else?
No.
All right, and then going back to where we started, palliative care survey recommendations, and Rebecca mentioned many of these are both in the first May presentation as well as this presentation on just the difficulties in getting people to respond and complete the survey because of the length and complexity. So this has several specifics in terms of streamlining and shortening the survey to focus on key areas of interest, strengthening communication and outreach efforts, enhancing the web-based survey delivery, and increasing beta testing, and then conducting the survey every 2 years. So if it's a regular survey, people anticipate it and have data available. So some of you may have comments on this based on participating and during the survey process.
Just a background question for Linda, and that is, or maybe Rebecca knows this answer, that this survey was mirrored off after a survey done in Colorado.
Colorado did a telephone survey. This became a web-based survey, which was supplemented by numerous
follow-up calls,
phone calls, emails. Rebecca's can tell you the tale of woe.
And did Colorado have similar response challenges?
They've done their survey, I think, 3 times. So it's become more routine. But Rebecca, do you want to?
Yeah, I think hospital was strictly focused on hospitals, or Colorado was strictly focused on hospitals as well. And there, I believe, if I remember correctly, it was somewhere between 6 to 9 months was their data collection period. So it was 3 times, at least 2 to 3 times as long as ours. So it did require significant manpower to get it done. So they were looking at, I think it was a total of 95 different hospitals, and we had 356. So that's quite a bit different as well, just in who we're outreaching to and the time commitment that was involved.
Thank you.
You know, Ben, I'm just going to say too, I did help make some calls for the survey. What I found is that I think organizations collect information very differently, which is why I think the recommendation is to try to customize that survey a little bit more to make it easier for those providers to actually complete it. A lot of people told me they felt like it was very difficult.
Yeah, I think you had mentioned previously trying to make it service specific.
Yeah.
Yeah.
What's challenging?
So basically tailor a survey for hospices, tailor one for hospitals, etc. Yeah.
Reggie,
I would concur. I would absolutely support that recommendation.
Aaron, did you hear any feedback from hospitals? She may have dropped off.
No, sorry, I was having trouble finding the mute button. I really have not heard much from the hospitals. but if I do, I can give you that feedback.
All right, thank you.
I know that MHA, the hospice network, and the other providers did work with their members to try to beat them over the head, encourage them to respond, but it was a lengthy survey, and we covered a lot.
Right. Okay. Any final comments on the recommendations, on specific recommendations that have come to mind, or your general thought? I mean, I think there's a lot of recommendations. My advice to staff is to maybe collapse some. We certainly recommendations that that apply to our partners at Medicaid. We'll be working closely with them in the coming month to make sure they, what their position or understand the implementation challenges that may exist for some of them. But any specific or general comments that people want to make now?
I think Dr. Kearney mentioned earlier, rather than doing new educational initiatives, building on or coordinating what exists currently and
would be helpful.
Supporting that.
Okay.
Are there any recommendations that were not covered here that should be included?
Offered.
I'm wondering, Dr. Kearney, again, briefly on the overall funding, that the point was made early in this presentation that there is money to be saved for many of these organizations with effective palliative care in their hospitals and their communities. And I would wonder, as we look forward, I know we will be talking about the cost of everything, but there is the other side, and many other states have proved this. We spent a lot of time in MedStar proving that we were, actually, if done well, you could actually good quality care, better care, and cost less. So I would just hope that message continues to echo when we're talking about funding these projects.
Good point.
That will be addressed in the report.
Yeah, I hear what you're saying. The challenge sometimes is that the savings do not flow exactly in line with the expenditures, and those that pay the bills don't oftentimes feel that claims just across the board with many of the value-based initiatives have met the promise. That's a challenge for the federal government. That's a challenge for state government, and that's a challenge for the participants in these programs as well.
Ben, this is under the umbrella of, I know, just a little bit enough, just enough to be dangerous. But in the total cost of care, when we look at hospitals and the metrics they're held accountable to, and what they might be penalized for, or what certainly contributes to their reimbursement from HSC or through the HSCRC, is there an incentive to each hospital to offer palliative care services? I know there's legislation that says if you're a hospital of 50 patients or larger, you have to have one. But for us to strengthen that, make it more robust, to be able to have those measures to demonstrate it's a program of merit in the hospital through the, and give the hospital credit for a quality program versus who's going to penalize for a high mortality rate. I think there's a way to kind of weave it in.
Yeah, I think obviously that's a piece of it, and we collected data from hospitals, but the push of this legislation is really community-based palliative care, and how can you move from, it's already required in hospitals, it may not be consistently done. How can you move out?
I think we can put a recommendation that calls for better alignment with incentives in the model. There is a post-acute care work group that convened earlier this spring that talked about incentives, but it focused primarily on integration, better coordination and integration with nursing home care, not any other aspect. We might, just as an offshoot of this work group, think about how some of this information can be incorporated. The challenge is that work group didn't really, as far as I know, did not discuss palliative care.
So right now, if one of the measures I look at for my inpatient palliative care teams at the hospitals is number of referrals to outpatient palliative care. All right, so how to help people really be discharged with these services that will keep them where they want to be at home, right, comfortably. So maybe this.
We should talk further about that.
Yeah, weave that in.
Yeah.
Thanks, Fred. So in terms of next steps,
Kelly had a comment.
Okay, guys, hold on a minute. We'll be incorporating the comments and trying to finalize the data and information. We have the information from other states, which you have on the table. We're going to be working on drafting the interim report. As Ben said, it's really more of a process report of how we've addressed the legislation, convened the work group, had several meetings and conducted the survey. The results and the recommendations will be in the final report. Sorry, there were comments from
Kelly.
Okay. Kelly, you had a comment.
Yeah, she put it in the chat, but certainly if you, the microphone is yours if you have anything you want to add to that.
Yeah, I didn't want to interrupt as everyone was talking, but I did review all of the materials that accompanied this meeting, and it really gave me a lot to think about. We do talk about this amongst my team. I do work in the Division of Home Health and Hospice Payment Policy primarily. And as most of you know, we're pretty limited by what the statute allows us to do, but that doesn't mean that we don't try to think of innovative ways to facilitate this discussion. I think it was mentioned earlier about the legislation that's out there to have a palliative care model through our innovation center. Obviously, we would assist our colleagues in that endeavor in providing any kind of technical advice that they may need. So I thought this discussion is really helpful. These recommendations I thought were fantastic. However we at the federal level can help, we will do so within, of course, we're limited in our parameters, but I do appreciate the all the time that's been spent in developing these recommendations, doing these surveys. I mean, I just found it, I think I spent most of the morning reading through this. So I really appreciate this. And it really does help because I've already engaged my team with some of the materials that you sent, just so that we're on the ready. Because I kind of feel like it would come to us last at the federal level, but this information is really informative as we have internal discussions. So I really appreciate the collaboration and all the work that you all have put into this.
Thank you.
Thank you. Okay, so we will, as I mentioned, we will be working on drafting the interim report and submitting that. We will meet again in August. We're still waiting for the results from the Google survey to know the exact date, but once we have a date, we will let you know and hopefully can accommodate as many people's vacation schedules as possible.
Can we kind of give people an idea of what the interim report, do we have in terms of table of contents, what they will see?
Right now, but basically we will go through the legislation, what was involved in terms of the scope of work, the formation of the work group membership, what was discussed at the meetings, some of which was what I presented at the commission meeting, kind of the state of where we are now. There is a lot of background information, literature search that Rebecca has worked on in terms of palliative care in the US, palliative care in Maryland, what some of the legislation has been. basically what is not included is the results, specific results of all of the survey questions, which you see here, and the recommendations. So the specifics we will get to in the final report, but it still covers a lot of ground.
Okay. Questions about the interim report? Okay. Right.
Or any other questions?
Any other questions before we adjourn? It looks like we're going to give you back 5 minutes of your time. Not a lot, but I think everyone's going to use it really valuably. Thank you again for a very productive meeting today. I appreciate all the comments we got, both those that made them verbally and those that were put in the chat. And again, thank you again, Rebecca, for all the work on this project. It's more than you maybe banked on, but it's good
and more challenging.
But we appreciate your team's efforts in putting this together. Also want to recognize the work of Linda, Catherine, Tracy on the MHCC team, as well as the collaborative efforts of the Hospice and Palliative Care Network in this work, and looking forward to continuing our progress towards producing that final report for the legislature later this year. So have a safe afternoon and a hopefully an enjoyable 4th of July. Hopefully you won't be traveling. I understand it's quite chaotic, but if you are, patience and peace and love.
Thank you.
Thanks.
Thank you all.
Thank you.
Thank you. Everyone have a good one. Thank you.
Bye now.
Bye-bye.
Getting it to you, I would like. Did you realize?
She is a dork, and I'm already.
It's been 2.5 years.
Done?
Oh,
yeah, he stopped. There you go. Okay. Here's Matt's face. Hit leave.
Matt's still on.